thank you all. I'm really pleased to be here and to share with you the work that we do um, at ACON and in our cancer programs for the LGBTQ community. Today, I'd like to, for you to take away, and I think Philomena has set this up really nicely for the things that I'll talk about. But I guess what I'd like you to take away is that the LGBTIQ plus communities are diverse, that there are barriers to accessing healthcare, and we also have lifestyle factors which may increase our risk for certain health issues. And these lead to poor health outcomes for parts of our community. And that LGBTQI plus people are often excluded, or data isn't collected on us, or sometimes grouped together in ways that hide some of the issues within our health behaviors in research. But there are ways that we can collect data appropriately about our communities and report that will make a difference. And also that LGBTIQ plus inclusive approaches to addressing research and health issues can make a difference in addressing the inequities that we face, not only for our communities, but also beyond our communities. So before I go further, I would like to acknowledge the traditional owners of the lands on which I'm coming to you from today, and that's the Gadigal people, as I'm based here in Sydney. And I'd like to pay my respects to elders past, present, and emerging, and also to extend my respects to any Aboriginal and Torres Strait Islander peoples who are joining the conference today. So I'll start off just with some background. Firstly, a bit about who we are as ACON. ACON is New South Wales' leading and Australia's largest community organization specializing in health, inclusion, and particularly HIV responses for people of diverse sexualities and gender. Our history, ACON previously went by the AIDS Council of New South Wales, so our history is very much in addressing HIV responses, but our work is much broader than that nowadays. We work primarily in New South Wales, but we do have a number of projects which have national reach, and including some of the cancer programs that I'll talk about today. We have a strong background in working closely with a range of partners, including governments and businesses, and over 35 years of working in the community. And yes, thanks, Patrick, for acknowledging that today is World AIDS Day. Just to give you a bit of background or overview of what the LGBTIQ community is, and kind of some of the definitions and acronyms and stuff that we use. Firstly, it encapsulates sexual orientation, and sexual orientation includes sexual identity, attraction, and behavior, and that includes people who identify as lesbian or gay or bisexual. Also, the acronym often includes intersex people, so people who have sex characteristics or innate variations of sex characteristics. It includes gender, and here looking at the spectrum of gender, both as a social concept, and that ranging from female on one side of the binary to male on the other, and non-binary, and a real range of gender identities in between those two. And also the gender experience, so that being transgender, which is a process of affirming a gender that is different to that was assigned at birth, and cisgender, which is identifying with the gender that you were assigned at birth. I think it's also important to acknowledge that the intersectionality of our communities. We are not just our gender or our sex or our sexuality. We also come from a range of different backgrounds. As part of my introduction, I'm a gay man, I'm a dad, I'm married, I grew up in rural America. I was a first-generation university educated. So I bring a complexity of kind of who I am to my life and to my healthcare, as do every other member of our communities. There are some real, I guess, gaps and issues in measuring the LGBTQ community. And I guess I should point out that I tend to use LGBTQ in my presentation. And that's because that's who ACON best represents. That's the communities that we closely work with. And we don't represent the intersex community in most cases. The intersex community is represented by its own peak body, Intersex Human Rights Australia. So, but in Australia, there are estimates of anywhere from 5 to 11% of the population identifying as LGBTIQ. The census does record same-sex couples living in Australia, but it doesn't actually count individuals. So, there's a much higher number of individuals rather than just the reported couples. But estimates are likely to underrepresent the community, particularly because of unwillingness to report our identities because of histories of discrimination and stigma. There's some cases where data is included, and here I'm looking at tobacco statistics. The New South Wales Population Health Survey doesn't report sexuality or gender at all in its population health survey results. And so here we see smoking rates with no option to look at it by gender or sexuality. The top here, the data is from the National Drug Strategy Household Survey, which does report information on sexual orientation, but groups homosexuals and bisexuals together in that report, where what we actually know from internationally from data shows that there are differences between both gay men, lesbian women, and bisexual people, and where we have limited data on transgender people, smoking rates vary quite a bit by those subpopulations. So when we group the homosexuals and bisexuals together in this case, we're masking actually some of the insights, the important insights as to the health behaviors within each of those subpopulations. A review of cancer clinical trials in LGBTQ plus people done a few years ago found that none of the 764 cancer trials that were reviewed reported data on sexual or gender minorities. So no trials reported that status. Only 2 patients were listed as having gender as not reported or unknown. And one trial actually was exclusionary to our communities because it defined its endpoint as penile vaginal intercourse. And so I think when, this is an important message, I think, for ethics committees, is when reviewing, thinking about who may be excluded and what impact that may have on those communities. I think particularly for our transgender communities, the impact of potentially drug trials on and their reaction or interactions with hormones is important to consider, not only for the trial itself, but also the ongoing care if that trial leads to a success and becomes normal care, but that people may be excluded then later from accessing that care because they weren't included in the trials. And what we know is that people from LGBTQ communities report lower levels of health, both physical and mental health, and they do report higher levels of different mental health issues, such as experiencing mental health conditions, experiencing stigma and discrimination, and experiencing social isolation. In cancer specifically, there is a lack of data in many areas, but what we do know is that there is evidence of higher smoking rates and higher alcohol consumption, lower cancer screening rates in some cancer screening programs. There's multiple barriers to accessing care. And we also see within cancer services that there's higher levels of distress. There is the majority of healthcare professionals feel comfortable caring for our community members, but they lack confidence and knowledge in many areas. and that there are unmet needs among LGBTQ plus cancer patients. And this has led to LGBTQ people being included as a priority population group in cancer control policies. So what I wanted to talk about for a bit is the difference it makes when we're counted in. So in many cancer control and broader health policy documents, we are seeing the inclusion of LGBTQ communities. The Australian Cancer Plan identifies our communities as a priority population group and includes strategies, and there was dedicated consultation, as does the New South Wales Cancer Plan. New South Wales also has a New South Wales LGBTIQ plus health strategy. The national strategy for the elimination of cervical cancer includes us as a priority population. And the federal government is also working on a 10-year action plan for LGBTQIA plus health. And the ABS, despite not recording sexuality and gender in the census, the ABS has released Standard 2020, which does outline how to collect data on sex, gender, variations of sex characteristics, and sexual orientation variables. And ACON itself has recommended community indicators for research, which we've been using for years, and as part of our ethics committee that we have. And just to note that there is also a similar ethics committee in Victoria. But we've developed our own recommended indicators that we've used, and these are easy to use. They're available on our website, but help to guide appropriate data collection that captures our community here, particularly with gender, asking a two-part gender question. And these help to inform what became the ABS Standard 2020, and they ensure that data is asked adequately and captured. Just a bit on ACON's ethics committee. Some of the things that we look for, or our ethics committee looks for, is the potential for direct or indirect benefits to our community members, the potential risks to our community members, consultation that's been done with our communities, including, recognizing that LGBTQ researchers are involved in the research themselves, and possibly inclusion of ACON staff as advisors or research participants, and also that the results are published and communicated to our communities. I also just wanted to touch back on an article about what's needed for inclusion in cancer clinical trials for our communities. This was a paper published last year, but really calling for a paradigm shift in cancer clinical trials to be inclusive. And I think this paper and some of the points here on the slide highlight some of the things I think that ethics committees can consider or question or look out for or advise on when you're reviewing applications for research. And I think these echo many of the things that ACON's ethics committee tries to look for and encourage or enable in research applications. So now I want to shift gears a bit and just highlight some of the work that we do at ACON, and that's on cervical screening, and show you, hopefully demonstrate what the difference in a more inclusive approach can mean, not only for our communities, but also other communities that may have barriers to accessing health services. And with this, I'd like to acknowledge that as a cisgender gay man, many of the stories and the perspectives that I'll share with you, and the research findings that I'll share with you, obviously are not my personal story, and I'd just like to acknowledge the people with the cervix that have participated in this and shared their experiences with us to inform the campaign, but also to tell their story in the campaign work that we do. So ACON's cancer brand called Can We has been working in this space in partnership with Cancer Institute New South Wales for many years. We started off in 2016, and we've run a number of campaigns around smoking cessation, breast screening, cervical screening, bowel cancer screening, and next year we'll be addressing alcohol and research, or alcohol and cancer risk. But I'll focus now on our work on the Own It campaign, which was run earlier this year. We started off looking at the barriers to cervical screening, and in here, there are several barriers that patients experience, particularly from our communities, but also more broadly. And I should say that when we looked at this campaign, this was an inclusive campaign of sexualities and gender, not just focused on the LGBTQI community, but we were seen as a partner to run this campaign by the Cancer Institute because we could be more inclusive and taking that more inclusive approach that the governments often can't take or don't take. So we looked at the range of barriers to cervical screening. Some of these, such as misinformation, which including advice from healthcare professionals that lesbian women don't need to have cervical screening if they've never had penetrative sex with a man, or the fear of penetration, particularly an issue for trans people, but also a number of people will have that experience, and also previous trauma. So some of these are more unique to our communities, but others affect different communities in different ways, including for some communities, their language and cultural issues. So we were commissioned to do a inclusive campaign for young people with the cervix to contribute to an increase in cervical screening. And our target audience was all young people with the cervix aged 25 to 35 years. And the campaign ran for about 6 weeks in January and February of 2023. When we developed this campaign, and with most of our campaigns, we follow this process, although we did flip a couple things here. Firstly, we recruited our community talent to share their experiences with cervical screening earlier in the process than we normally would. We did that so that that could inform the script development. So we actually based our script around the stories that people from the community had shared with us. And then we aligned those with the key messages that we needed to get across as part of the campaign, particularly informed by broader formative research and from the Cancer Institute and the needs of the screening program. And then we focus tested and produced the campaign. I just want to touch on some of the findings from our focus testing. And here I really want to focus on the real challenges, I think, in people not feeling empowered in cervical screening. And I think this is probably, when we talk about research or healthcare in general, I think what we want to see is people engaged and empowered in making those decisions and participating. But what we actually saw in this, particularly with cervical screening, is that people just felt they had no options, they had no choices, they had no control over cervical screening. And so our campaign was really trying to challenge that and really focused on empowering people. We also, as part of this self-collection, was a new opportunity. It was new news. There was very little awareness. People were very interested in it and saw it as an opportunity to take control of their cervical screening experience. But there was also reservations that one is they weren't sure that they could do it accurately to produce a quality sample that could be analyzed, but also that if they were denied this after requesting it, that they felt that it would negatively impact their future screening behaviors. So we needed to make sure that if we promoted this, that they were actually going to be able to follow through and receive this care. So now I'm going to just show you the campaign that we developed. So hopefully this will play. I may just check, see if I've shared audio.
For my cervical screening test, I chose to find a doctor I could trust.
I chose to use a self-swab at the clinic.
I chose to insert the speculum myself.
I chose to bring a friend for support. I chose to educate myself about the test.
I chose to talk to my mob about cervical screening.
I was nervous.
I've had some trauma that made me apprehensive. I put off the test for a long time.
Getting tested before, I had felt so vulnerable.
The idea of the speculum had always put me off.
I was wrongly told I didn't need a test because I only have sex with women.
Having your friend there can put you at ease.
Your doctor can explain how to take the swab. Being able to self-swab in private now is a game changer.
By taking control, your experience can be positive.
Because we all know that a healthy mob is the best mob.
If you have a cervix, the test can save your life.
It's your cervical screening test. Own it. For my cervical screening.
So I just want to share, this is a very busy slide and apologies for that, but I just want to demonstrate that we had, in our campaign evaluation, we had broad representation across many different demographic groups. And so the campaign overall, we generated good traffic and good reach with our digital analytics. But also 44% of all respondents recalled seeing the ad, particularly higher in the 25 to 35-year-old target audience, but also LGBTQ plus people had higher recall of the campaign than heterosexual people, and strong engagement on social media. There was strong reporting of intention to take action, or 53% of the 25 to 35-year-olds had taken some action already, and 83% reported that they were motivated to take action when they were next due for a screen, these are really positive results, and we're very pleased with these. Also, the self-collection message seemed to resonate more strongly with people than some of the other messages, which is great news about promoting self-collection. And we see, growing knowledge of self-collection as an option for cervical screening. I just wanted to touch on just a couple other things that ACON has done in this space. One is that we have letters available on our website that people can send to their GPs that provide information that will help reduce barriers to their services, including their preferred names, pronouns, preferred language for their body parts, and trauma-informed options that the patient can select. We have also run a checkout clinic, which is a LGBTQ inclusive sexual health clinic. It's peer-led, and the clinic saw about over 500 patients between January 2018 and March 2020, with very high satisfaction rates and willingness to recommend the service to others. It took a parts and practice and trauma-informed approach, which is really important to providing inclusive care, and really positive comments from clients who had used the service about their experience. And, I think particularly experiences that they don't get elsewhere. So thank you. I'm happy to take questions if we have time. And I'll stop sharing.
Thanks so much for that, Scott. Really impressive work that you've got going on. There's a lot of comments in the chat about how it's life, your campaigns are life-saving. And yeah, I've got goosebumps actually. Unfortunately we don't have much time for questions, but I was wondering if you could just leave us with one final quick comment on how we can be more inclusive generally with our research. You've got a lot of, I know there's resources available, but if a researcher or an ethics committee member was looking at a project in front of them, how would they know that it's being sexually and gender appropriate and inclusive?
So I think looking to see, are they including questions on sexuality and gender? I think too often we look to, there's reservations about asking that information as possibly being unnecessary or too intrusive, or and which I think, I think we need to include that data and report that data so that then we can understand where there are differences or where there are not. And I think the important message for me to portray is that, especially from this recent cervical screening campaign, is that taking a more inclusive approach will benefit the communities that we're targeting, particularly like the LGBTQ community in this campaign. But it does have benefits beyond that for other communities. I think taking trauma-informed approaches have huge benefits for people with disabilities, and I think that's been seen or argued for those. So rather than looking at all of the different communities and needing different approaches, when we're more inclusive, I think would benefit everybody, not just those target communities.
Yeah, very wise words. Thank you, Scott. Thank you.